This chapter reviews non-lesional spontaneous intracerebral hemorrhage. Introduction. Primary spontaneous intracerebral hemorrhage is defined as hemorrhage within the brain parenchyma, possibly extending into the ventricles in the absence of a traumatic etiology or an underlying tumor or vascular anomaly. Most commonly, such spontaneous ICHs result from hypertensive arteriopathy or cerebral amyloid angiopathy. Spontaneous intracerebral hemorrhage represents 10 to 15% of all strokes, but accounts for more than half of stroke-related mortality and severe disability. Volume of hematoma, location in the brain, patient age, and neurological condition can influence mortality and functional outcome. Recent evidence has emerged in favor of specific medical and surgical interventions, with evolving concepts about optimal management of varying facets of this disease. Epidemiology and prognosis. The incidence of spontaneous ICH is about 24.6 cases per 100,000 people per year, and it is expected to double by the year 2050 with the increasing use of anticoagulation, antiplatelet medications, and an aging population. Although it represents only about 15% of all strokes, primary spontaneous ICH is associated with a higher rate of mortality, with surviving patients having significant functional deficits. More than 80 years old, hypertension, cerebral amyloid angiopathy, African American ancestry, Japanese, Chinese ancestry all contribute to increased risk of suffering an ICH. Smoking, drug abuse, and heavy alcohol intake are modifiable risk factors that also contribute to brain hemorrhage. Volume on admission is a critical factor in determining mortality and functional outcome. The hematoma can be visualized on a non-contrasted head CT and measured utilizing the ABC2 method. ICH volume is the strongest predictor of 30-day mortality regardless of hematoma location. Rebleeding, hematoma expansion, low Glasgow Coma Scale, and comorbidities worsen the prognosis. Patients with hematomas larger than 60 milliliters combined with a Glasgow Coma Scale score of below 8 have a predicted mortality rate of 91% within 30 days. Calculating the volume of ICH from axial CT scan images. Here we explain the ABC2 method. An example follows. On the cut that has the largest diameter of hemorrhage, axis A is selected. Within this same cut at 90 degrees, axis B is selected. Then, by counting the axial cuts of a predefined thickness, 5 millimeters in this example, the formula can be populated. This formula is derived from the volume of a sphere. Pathoetiology. Primary ICH occurs after a parenchymal arteriole in the brain ruptures. The processes that lead to arterial pathology include hypertension, which is the most common source of primary spontaneous ICH. Hypertension leads to vascular remodeling that leads to the formation of Charcot-Bouchard aneurysms, which can then rupture. Hypertensive ICH more commonly occurs in the putamen, caudate, thalamus, brainstem, and deep cerebellar nuclei. Small vessels located in these areas are prone to suffering such changes. Cerebral amyloid angiopathy is common in the elderly population, typically presenting as lobar bleeds. CAA can be asymptomatic and shown as microhemorrhages, which are best seen on MRI susceptibility-weighted sequences. CAA is the result of amyloid deposition within the intracranial vessels, including cortical and leptomeningeal arterioles, capillaries, and veins. This deposition leads to gradual loss of smooth muscle cells, resulting in fibroid necrosis. This subsequently leads to progressive weakening of the vessels, which can then rupture. A case example. A 58-year-old man with known hypertension and a history of noncompliance with antihypertensive medication was seen after the acute onset of left-sided hemiplegia and hemisensory loss. Head CT, shown here with an axial image, demonstrates a right thalamic hemorrhage with extension to the internal capsule and spillage into the lateral ventricular system. Blood pressure on admission was 180 over 100 millimeters of mercury. Neurological exam revealed lethargy and a strength score of 0 out of 5 on the left hemibody. This case scenario is used to illustrate that patients under the age of 70 with deep hemorrhages have a likely etiology of hypertension, as the history suggests. Systemic anticoagulation and antiplatelet therapy can also be a key source of ICH. Anticoagulation is a known risk factor for spontaneous ICH with an 8 to 19-fold increase in the risk of ICH. Anticoagulated patients also have larger hematomas on presentation and have higher mortality rates. The NOACs, or novel oral anticoagulants, are associated with a lower incidence of ICH when compared to warfarin. However, these have limited reversal agents. Antiplatelet therapy also contributes to ICH, but to a lesser extent. The PATCH trial did not confirm a benefit of reversal of antiplatelets, but possible harm from administering platelet transfusions in an attempt to reverse antiplatelet medication. Drug abuse. This is more common in younger patients, and there is an association between ICH and sympathomimetic agents such as amphetamines and cocaine. Hemorrhage most commonly occurs within hours of its use. It is believed that a sudden and transient increase in blood pressure leads to vessel rupture. This may occur in deep locations such as those from hypertensive ICH, but can also be lobar, subarachnoid, or interventricular. Patients with an ICH require a complete history to assess for risk factors as well as anticoagulation or other medication use. Coagulation profiles and toxicology screens are completed as they represent key modifiable factors in addition to blood pressure control. Hematoma location. Deep hemorrhages. The putamen represents the most common location for spontaneous ICH, almost always associated with hypertension. The thalamus and caudate represent other locations that are common for spontaneous ICH. Lobar hemorrhages, most frequently located in the subcortical white matter of the frontal, parietal, or occipital lobes. These are typically secondary to cerebral amyloid angiopathy, chronic anticoagulation, coagulopathies, amongst other causes. Lobar hemorrhages may present with multiple small hemorrhages. The rule of thumb is that deep hemorrhages tend to be the result from hypertension. Lobar hemorrhages in patients older than 70 tend to be from amyloid angiopathy, but other causes such as anticoagulation should be considered. Other hematoma locations. Brainstem hemorrhages. These are most likely secondary to chronic hypertension, most frequently occur in the pons, and are devastating in many cases, carrying a poor prognosis. Patients typically present either posturing or in a comatose state. Cerebellar hemorrhages also most likely are secondary to hypertension. They represent 5 to 10% of all ICHs. With cerebellar hemorrhages, there can be significant improvement with emergent evacuation. Symptoms secondary to brainstem compression and obstructive hydrocephalus can be the cause of a patient's poor exam. Posterior fossa decompression can be considered and are associated with marked short-term improvement. Any mass lesion in the posterior fossa should be assessed for causing brainstem compression and or hydrocephalus. A case example. A 58-year-old man on warfarin with an admission INR of 3.5 for a prosthetic mitral valve was seen after the acute onset of a severe headache, nausea, and vomiting. While en route to the hospital, he became progressively more lethargic and was not arousable on admission. Figure A shows an axial CT scan demonstrating a 45 milliliter right-sided cerebellar hematoma with compression of the fourth ventricle and brainstem. This patient's exam is explained by brainstem compression and hydrocephalus, not solely the destruction of the cerebellar tissue from the hemorrhage. Subsequently, the coagulation profile was corrected, the blood pressure was controlled, and the patient was taken to the operating room for a right frontal external ventricular drain to treat the hydrocephalus. This is not shown. An emergent suboccipital craniectomy and hematoma evacuation were performed, with the post-operative results shown in Figure B and C. In Figure B, air can be seen anterior to the brainstem from the relief of the pressure. However, the fourth ventricle is still obstructed, necessitating CSF diversion from the EVD. The patient was ultimately discharged to a rehabilitation facility ambulating with assistance. Interventricular hemorrhage most commonly is a result of interparenchymal hemorrhage that extends into the ventricular system. It is associated with a worse prognosis and has a high mortality rate. The clinical course is complicated by blood breakdown products inside the ventricle, eventually leading to hydrocephalus. An EVD, or external ventricular drain, is the standard of care for obstructive hydrocephalus in IVH and ICH, and also prevents mortality. EVDs are prone to clotting and may require additional management or exchange. The CLEAR trial, which we will talk about in subsequent slides, showed improvement after administering RTPA in patients with IVH greater than 20 milliliters and aggressive treatment to greater than 80% of clot removal. This has led to better functional outcomes at 180 days. Medical management. Medical management is best carried out by a multidisciplinary team. Patients are susceptible to the complications common in other ICU patients. Initial management after standard principles of critical care, such as airway breathing and circulation, and etc., are control of systemic hypertension and correction of the coagulopathy. Early CTA should be performed to assess for spot sign and also to screen for potential etiologies of the hemorrhage. Neuroimaging to prove stability should be completed at 6-hour intervals until the hematoma is stable and can be used to further identify potential etiologies such as a vascular malformation or a tumor. CTA is the preferred imaging modality for vascular etiologies and MRI to rule out tumors. Key aspects of medical management. The treatment of hypertension. Hypertension is associated with worse outcomes and potentially rebleeding in hematoma expansion. Multiple studies have looked at treating blood pressure aggressively or to the historical guideline of less than 180 millimeters of mercury. This has been looked at, and the primary outcomes of these studies have not shown a benefit from aggressive treatment. Some of these studies have shown that there is an increased rate of renal, cardiac, and neurological adverse events. The current guidelines from the American Heart Association and the American Stroke Association are for patients that present with a systolic blood pressure of 150 to 220 millimeters of mercury. It is safe to lower the blood pressure to 140 millimeters of mercury. This is Class 1, Level A evidence. Blood glucose control. Both hyper and hypoglycemia is detrimental in ICA patients. The current American Heart Association, American Stroke Association guidelines suggest that glucose should be monitored in all ICH patients. Hyperglycemia and hypoglycemia should be avoided. This is Class 1, Level of Evidence C. Temperature management. Fevers commonly occur in ICH and IVH patients. The maintenance of normothermia has not been clearly demonstrated as beneficial to outcome. The current American Heart Association and American Stroke Association guidelines say that treatment of fever after ICH may be reasonable. This is Class 2B, Level of Evidence C recommendation. Treatment with hypothermia should be considered investigational in ICH currently. Systemic anticoagulation. The prevention of hematoma expansion and the urgent need to minimize the size of the clot are the primary goals of emergent ICH management. The mainstay of therapy is blood pressure control and normalization of the coagulation profile. These goals hold true even in patients on systemic anticoagulation for thrombotic conditions with a risk of ischemic complications. An INR of greater than 3 is associated with higher ICH volumes, greater incidence of hematoma expansion, and worse neurological outcome. FFP and vitamin K are the most widely used agents for reversal of warfarin-induced coagulopathy. FFP must be thawed and typed, which can lead to critical delays. Large volumes may be required to achieve a clinically significant effect, thereby leading to volume overload, heart failure, and transfusion-related acute lung injury. Intravenous vitamin K has a slow onset, taking approximately 6 hours to achieve a therapeutic effect. The American Heart Association and American Stroke Association recommend replacement of vitamin K dependent factors and IV vitamin K. This is Class 1, Level of Evidence C recommendation. Prothrombin complex concentrates, or PCCs, are an option for rapidly reversing warfarin-induced coagulopathy. This is a recommendation that is Class 2B, Level of Evidence B, and is rapidly becoming the standard of care around the United States. Direct thrombin antagonists and factor Xa inhibitors are being used increasingly as an alternative to warfarin for specific conditions. These have been studied in the RELY, ROCKET-AF, and Aristotle studies and found to be associated with a lower incidence of intracranial hemorrhage when compared with warfarin. The drawback of these medications is that they have a limited pharmacological means of reversal. The American Heart Association and American Stroke Association guidelines recommend that in the case of bleeding, prothrombin concentrate complex or recombinant factor 7A can be considered on an individual basis. Activated charcoal can be used if the last dose was taken in less than 2 hours. Adnexa was approved in the United States in 2018 as an antidote to rivaroxaban and apixaban. Reversal of dabigatran, which is a reversible inhibitor of factor 2A or thrombin, can be achieved with idrucizumab. Antiplatelet agents. Aspirin is associated with an absolute risk increase of ICH of 12 events per 10,000 persons, which is higher in the elderly population. Dual antiplatelet therapy is commonly used in patients that have undergone endovascular procedures. Dual antiplatelet therapy increases bleeding risk. These agents have also been found to be an independent predictor of hematoma expansion. Platelet function is irreversibly blocked by these agents, and normal platelet function is gained back 7 to 8 days after discontinuation. Management of intracranial pressure. Elevated intracranial pressure can be present in patients with ICH. This can be from mass effect, interventricular hemorrhage, obstructive, or communicating hydrocephalus. Immediate intervention should include elevating the head of the bed, controlling the respiratory rate, sedation, and the administration of paralytics can all be used for medical management. The American Heart Association and American Stroke Association recommend the use of an external ventricular drain catheter. This recommendation is Class 2A, level of evidence B. Coagulopathy should be corrected before inserting an external ventricular drain catheter. When the intracranial pressure is refractory to medical therapy, surgical decompression can be considered. Corticosteroids should not be administered for elevated ICP in the setting of intracranial hemorrhage. This recommendation is Class 3, level of evidence B. Seizures and anti-epileptic medication. Seizures are rarely associated with spontaneous ICH, occurring in approximately 4.2% of patients. Seizures, which are uncontrolled, can lead to elevated ICP and elevated blood pressure and require intravenous anti-epileptic therapy. The American Heart Association and American Stroke Association recommend that clinical seizures should be treated with anti-seizure medications. This is Class 1, level of evidence A recommendation. Patients with a change in mental status who are found to have electrographic seizures on EEG should be treated with anti-seizure medications. This recommendation is Class 1, level of evidence C. Continuous EEG is recommended in ICH patients with a decreased mental status. This is a recommendation that is Class 2A, level of evidence C. Prophylactic anti-seizure medication is currently not recommended by the AHA-ASA. This is a Class 3, level of evidence B recommendation. Other systemic complications in the setting of ICH include coronary artery disease and arrhythmias, which may be exacerbated in the setting of ICH. Deep vein thrombosis and pulmonary embolism are also high risk for occurring in patients with ICH. DVT prophylaxis with subcutaneous heparin is safe 24 hours after hematoma stabilization. This has been shown to reduce the rate of pulmonary embolization without affecting hematoma size. Other aspects that need to be considered in ICU patients with ICH are nutritional aspects, aspiration precautions, as well as pneumonia precautions. Furthermore, long-term Foley catheterization can contribute to urinary tract infections, and best practices should be implemented. This table is a selected list of medical trials completed in the past decade for the treatment of ICH and IVH. This table and these trials heavily represent the data that was used to construct the American Heart Association guidelines that we currently use today. If we look at this table, the first 3 trials on the list are all for blood pressure control. Interact, Interact 2, and Attach 2 are trials that look at aggressive blood pressure lowering in the setting of ICH. These trials showed no significant difference in their primary outcomes. However, within these trials, secondary predefined outcomes did show a potential signal of benefit. That is why the current AHA guidelines for blood pressure control in the setting of ICH are to lower blood pressure to a systolic blood pressure of 140 millimeters of mercury, while taking into account that any lowering beyond that may compromise renal or cardiovascular systems from ischemia. The next trial on the list is the FAST Phase 3 trial, which completed enrollment in 2007. In this trial, Factor 7A was administered to patients with ICH within 4 hours of the onset. There was no effect on mortality or MRS in this study. Hematoma growth was reduced in the high dose with increased incidence of arterial thromboembolism. The next study, the PATCH study, completed enrollment in 2015. This study looked at platelet transfusion for patients on antiplatelet medication. There was no difference in the functional outcome of patients with a signal for worse outcome in patients receiving platelet transfusion for reversal of drugs such as aspirin. The key aspect of this trial, it does not assess patients that are undergoing potential interventions such as going to the operating room or having an EVD inserted. The next two trials on the list, the IDEF trial, looked at deferoxamine, which is a chelator. This did not show a difference in MRS outcome when administered to patients within 24 hours who had an ICH. This is, however, a novel mechanism that hasn't been studied elsewhere in the ICH literature to such a robust degree. The TICH2 study, which completed enrollment in 2017, administered tranexamic acid to patients, which reduced the hematoma size, but had no effect on MRS. The takeaway from this is that one of the main primary outcomes, which is the main outcome that is needed to be achieved in ICH, is not an intermediate outcome such as reducing hematoma size or looking at death. The main outcome that we want to achieve is that we want to improve functional outcomes for our patients. These studies have focused at the main modifiable risk factors. The first three trials look at blood pressure control, which is one of the mainstays of treatment in trying to improve one of the things that we already know works so well. The PATCH trial looks at reversal of a common medication such as antiplatelet medications and its reversals. These studies are trying to benefit in an area that we already know works. The last two trials are trying to look at reducing hematoma expansion because we know that hematoma expansion ultimately does have an effect on MRS, but in these trials, it was unsuccessful in showing that that translated to better functional outcomes. In the next part of this presentation, we'll look at surgical management. This is an area that is actively being studied given the successful results in protocolized case series. The most compelling are the MISTY and CLEAR trials that have identified thresholds of evacuation that may be vital to affect functional outcome in ICH. Surgical hematoma evacuation has been associated with a decreased 30-day mortality rate. Emergency hematoma evacuation remains a life-saving intervention in younger patients with large ICH volumes who are deteriorating clinically and in patients with cerebellar ICHs. The number of surgical trials for the management of ICH have increased exponentially over the last 20 years. The STITCH trial was a key trial that compared hematoma evacuation via open craniotomy versus medical therapy. This study showed no difference in its primary outcome between the two therapies for a favorable outcome or death. However, multiple post-hoc analyses show a strong signal to benefit in the open craniotomy group. This further motivated the STITCH 2 trial, which looked at lobar hematomas near the surface. However, this study also showed no benefit over medical management in its primary outcome. Post-hoc analysis again identified multiple areas where there's a strong signal of benefit for surgical management. A case example. Here we show surgical intervention for ICH. From left to right, panel A shows an admission CT scan of a 54-year-old patient with an acute hypertensive putamental hemorrhage. The hemorrhage is measured at 42 milliliters in volume, causing hemiparesis and mild confusion. A CT scan, panel B, shows the same patient on post-admission day 1, with the patient becoming more lethargic. Panel C and D show CT scans after undergoing a left-sided craniotomy for hematoma evacuation with mild residual ICH. This scenario would be something reminiscent of a patient that was enrolled in the STITCH 1 trial. The next trial worth a few talking points is the MISTY trials. The MISTY trials were motivated after the failure of open craniotomy trials such as Stitch 1 and 2. The MISTY trials relied on an alternative technology and methodology to reduce the morbidity and mortality of ICH. The figure above highlights the MISTY procedure for hematoma evacuation. In panel A, the MISTY procedure is being carried out with the use of a dandy needle or a hard cannula within the CT scanner procedure room. That way, as aspiration of the hematoma occurs, it can incrementally confirm the placement of the cannula. Panel B shows a patient with an axial CT scan showing a 37 milliliter ICH. Panel C shows after initial aspiration, a soft catheter is then placed and left within the hematoma. The hematoma evacuation is then further completed by the administration of RTPA. Panel D shows the final result with 1 milliliter of RTPA given 3 times, reducing the hematoma volume down to less than 1 cc. This avoids an open craniotomy and is a minimally invasive way of achieving hematoma reduction. MISTY 2 was a trial that did dose optimization of RTPA. Doses of 1 milligram every 8 hours for up to 9 doses showed the best clearance rates without increasing hemorrhagic complications. Cornerstones of the MISTY procedure. These cornerstones have broad implications for the treatment of ICH. Number 1 is clot stability is required to be demonstrated. This is done with 2 CT scans 6 hours apart showing no change in the size of the hemorrhage. In addition, a correction of all coagulopathies are required prior to surgical treatment. Number 2 is etiology screening. Vascular imaging with a CTA, MRA, and or an MRI are necessary to rule out underlying vascular pathologies. If found, patients are not suitable for the MISTY procedure. The MISTY procedure was piloted as well as a phase 3 study was completed. The results of the phase 3 study showed that surgically treated patients did not show a significantly better functional outcome by measurement of MRS of 0 to 3 versus 4 through 6 at 1 year compared to the medically treated group. The MISTY procedure, however, did achieve significantly lower mortality rates than the medical arm. A higher extent of hematoma removal was associated with achieving a better modified Rankin score. End of treatment volumes of less than 15 milliliters or removing greater than or equal to 70% of the hematoma removed increased the likelihood of achieving a good functional outcome. Furthermore, there was also a higher probability of survival with achieving less than 30 mils of end of treatment volume or after removing greater than 53% of the hematoma. We also learned that surgeons with greater experience achieved better evacuation rates. This table looks at past completed surgical trials for the treatment of ICH. The first trial here, for historical reference, was McKissock et al., completed enrollment in 1961 and looked at craniotomy versus medical treatment. There was no difference in the primary outcome, but there was a reduction in hematoma size. The more modern era, which starts with Stitch 1, completed in 2003, was a robust study that looked at 503 patients randomized to craniotomy versus those undergoing medical treatment. There was a reduction with surgery in the size of the hematoma, but no difference in the primary functional outcome or mortality. Within this study, there was a signal that some patients with lobar hematomas near the surface may benefit. This motivated Stitch 2, which was completed in 2012. Stitch 2 specifically looked at patients with lobar hematomas who underwent craniotomy versus those undergoing medical treatment only. Again, there was a reduction in hematoma, but no functional outcome benefit was achieved in this study. The MISTY 2 and MISTY 3 trials looked at ICH with a new stereotactic thrombolytic-based therapy to reduce ICH versus the medical arm. There was no difference in the primary outcome of MRS. However, there was strong signal that those patients that achieved smaller hematomas with thresholds of less than 15 milliliters or greater than 70% reduction had a much higher probability of achieving a good functional outcome of 0 to 3. This was very similarly capitulated in the CLEAR 2 and 3 study, which looked at IVH. In the CLEAR 3 study, patients were given interventricular catheters and randomized either to receive RTPA versus placebo. Again, RTPA significantly reduced the volume of hematoma, but this did not make a difference in the primary outcome of MRS scoring. The next 4 studies listed here are not as robust, but are looking at more novel therapies for intervening on ICH. A few key notes on surgical management. Although we have just reviewed multiple clinical trials that have not shown a benefit for functional outcome in the setting of ICH, there does maintain a role for surgery in some ICH patients. Decompressive hemicraniectomy for mass effect is a safe procedure that may improve outcomes in select patients with ICH. In addition, cerebellar hematomas do benefit from surgery for all hematomas that are greater than 3 centimeters in diameter or have greater than 15 milliliters. This type of surgery is completed via a suboccipital craniotomy or craniectomy. A case example. A 69-year-old female with hypertensive right ICH with extension into the ventricular system resulting in casting of the right lateral ventricle as well as the third and fourth ventricle. The patient was increasingly somnolent. Panel A shows this with an axial section above and a coronal section of the same patient below. Panel B shows emergency placement of an external ventricular drain into the less casted ventricle to control ICP, along with a second catheter placed into the right lateral ventricle directly into the clot with all catheter perforations in contact with the clot. In panel C, 3 doses of RTPA were injected into the right lateral ventricle every 8 hours at a dose of 1 milligram per milliliter, resulting in resolution of the ventricular clotted blood as well as clearance of the third and the fourth ventricle. This patient did not require a shunt and was discharged with an MRS of 2 recorded at 3 months. This table looks at ongoing surgical trials that were recalled from clinicaltrials.gov. These trials have ambitious enrollment goals and are utilizing MIS or novel technology for the treatment of ICH. A key takeaway from this table is that the primary endpoints of these studies are mostly related to functional outcome. It has previously been shown that MIS technology and MIS utilization of surgical techniques for the evacuation of ICH and IVH has a significant impact on saving lives and reducing mortality. Over the next 5 to 10 years, multiple ambitious trials will likely be successful in showing a benefit for surgical intervention for ICH. The possibility that this does not happen will only be because the medical treatment of ICH is also rapidly advancing at a rate similar to or maybe even superior to that of surgery. Thank you. This is the end of the presentation. Highlighted here are a few selected references that all general practitioners should be generally familiar with for the treatment of spontaneous ICH.